I had ECT because at the time my doctors did not recognize that I was having two problems. I initially had psychosis, and they did not recognize that it was secondary to fungal hepatic encephalopathy. Some people, you might have known that or heard of that as like brewery syndrome, where your body is making alcohol. Although I had never tasted alcohol, my brain was basically marinating in alcohol because of the amount of fungal byproducts I had in my system.
And so did they misdiagnose that as depression?
Well, initially they misdiagnosed it as bipolar with psychosis. And then because the psychiatric medications made me worse and my psychosis was no longer contingent on mood, they decided that my real diagnosis was schizoaffective disorder, bipolar type with catatonia. And when I didn't respond to the medications, they said, we need to give you shock treatment.
So today I am glad to be joined by Sarah Price Hancock. She is a prominent figure in the movement advocating for ECT harms, and she's going to be sharing her story today. But Sarah, before we kind of jump into all of that, I'd like you just to introduce yourself, just briefly sort of catch the audience up on the kind of work and advocacy that you do.
Certainly. So I am a certified rehabilitation counselor and a former professor of clinical psychiatric rehabilitation at San Diego State University. While I was doing my graduate work, I needed to understand how to return to work because I was living with ECT injury. I had just quit ECT against medical advice the year before I started my graduate program. And I knew the only way I would be able to be successful in that program was if I were able to access appropriate, requisite academic accommodations. The only way I could get academic accommodations was if I were to get comprehensive neuropsych evaluation and also the physical, evaluation for some of the problems that I was having. For example, with the electricity traverses the entire spine, and I have spinal issues, so I needed a special chair. At the time, I was not using a wheelchair. I needed a special chair, and I needed some adaptive equipment. And the only way to get that equipment was if I could prove that I needed it. And so until that point, my psychiatrist had categorically refused any referral for comprehensive assessments for balance or vision or neuropsych testing regarding my memory because they kept saying my memory would come back. And a year of this, I was like, dude, sorry, but it hasn't yet come back and I want to move on with my life. And so my outpatient psychiatrist was a gem, and he was like, you know what, Sarah, you're doing so well. You've always wanted to go to graduate school. You need to go to graduate school. I'll refer you for the comprehensive neuropsych testing. So I did the comprehensive neuropsych testing, and the results were such that they identified mild cognitive impairment. They identified that it took me an inordinate amount of time to, at the time, find my words even, and also to read and process information. And so because I fell so far off the standard of normalcy in these tests, I was qualified to have double time on my tests. Double what my peers had. And I qualified to have all of my lectures recorded so that I could review those lectures later after class. And I qualified for a note taker so that I could have someone else concentrate on taking notes, because my coordination of writing while processing information I was hearing had been severely compromised. And this was a huge standard, like massive deviation from my baseline, because prior to ECT, I had not only graduated with a pretty decent GPA, all things considered. I didn't quite meet the honors category, but I did a great job at BYU. And I had, I forget what I was thinking. Oh, when I was at BYU, I had actually volunteered with the university as a university interpreter for campus events and devotionals and plays and, those kinds of things. So I was actually interpreting in American Sign Language at the university level. And so that requires a lot of, processing your language, understanding what you're saying, and then being able to coordinate your muscle movement, coordinate the motor output in response to the sensory input. And I had lost that capacity entirely. And so now I couldn't even listen to a lecture and take notes to keep up with the lecture. So gratefully, the university found someone in my classes, and I owe them so much because they took all notes. They shared with me all of their notes, and I was able to participate and graduate on time because I was given these academic accommodations. I did so well in my program, and I had such remarkable professors and cohort. They basically decided to use me as their case study for our 3-year program. And so any time any student needed assistance, needed a volunteer person with a psychiatric disorder to do a case study on, or to, do an assessment for, or such as that, they frequently chose me. And so consequently, I was connected with assistive technology that typically aren't given to people at that time, because I had students who were doing comprehensive assessments and then writing well-documented reports, well-researched, well-documented reports. So I was able to use a lot of assistive technology.
So let me ask this just to focus in.
Yes.
Why did you end up getting ECT?
That's a good question. I had ECT because at the time my doctors did not recognize that I was having 2 problems. I initially had a psychosis, and they did not recognize that it was secondary to hepatic encephalopathy. And so I had a fungal infection, and basically I had I guess it was fungal hepatic encephalopathy. And some people, you might have known that or heard of that as brewery syndrome, where your body is making alcohol. And so though I had never tasted alcohol, my brain was basically marinating in alcohol because of the amount of fungal byproducts I had in my system.
And so did they misdiagnose that as depression?
Well, initially they misdiagnosed it as bipolar with psychosis. And then because the psychiatric medications made me worse, and my psychosis was no longer contingent on mood, then they decided that my real diagnosis was schizoaffective disorder, bipolar type with catatonia. Okay. And so I didn't respond to the medications. And when I didn't respond to the medications, they said, we need to give you shock treatment.
And how long was it between when you started having symptoms and when you got ECT? Was that several months? What was the time course? Yeah.
So my very first psychotic break was in right after I'd returned from my mission for the Church of Jesus Christ of Latter-day Saints. Within like 3 months, I got really bad pneumonia when I was at BYU. And so they put me on antibiotics. And soon thereafter, I had my first psychotic break. And I was taken off the BYU campus by campus security and taken to the hospital there close to BYU. And they looked at, all of my symptoms, and they knew that I had a family member who was I had 2 family members who had been diagnosed with bipolar disorder. So they assumed that that was my diagnosis and went with it. There was no recognition that I didn't have these symptoms before the antibiotic, and there was no like spinal tap or, anything of that nature.
Okay. And so when you got ECT, do you remember what they told you about it?
No.
Okay.
But from 98, so what happened was I was first diagnosed and medicated in 98. And then I was able to return to BYU and complete my degree. It took me an exponentially longer time, but that was in 98. I finally graduated from BYU in 2002 in April. And then that following December is when they were like, you know what, we've tried every medication that's available at this time. And so we need to try something else. And so it wasn't until December of 2002 that I was first given shock treatments.
And how many treatments were you given in your first round?
My first round, I was given, let's see, I only recently got my medical notes. I was given more than 50, if I remember correctly. The problem was, I wasn't responding to the ECT. And so they just kept giving me back-to-back acute courses of ECT. So that's 3 times a week, 3 times a week, 3 times a week, twice a week, twice a week, once a week. Okay, she's not getting better. 3 times a week, 3 times a week, twice a week, twice a week, once a week. Oh, she's not getting better. Basically, they were the living embodiment of Einstein's definition of insanity.
And so were you injured after that first round, or did you undergo subsequent rounds of ECT?
I suspect that I was injured in that first round. My parents indicate that I was injured in that first round. I speak this kind of like as a third person because by the time I had the second round of ECT and finished that was from 2002 to 2009. By the time I was finished with that, I had erased the first 34 years of my life, the life experience of the first 36 years of my life. So I don't know if you can see it, but on this bookcase behind me, I have 38 volumes of journals. And so I basically pieced together my life based on the journals that I wrote since I was 12.
Okay. And, I know you've had spinal injury now from the shock treatment. Was that apparent after the first rounds, or was that something that emerged later on?
I really couldn't tell you. I know that it wasn't until I started having I need help, because what had happened is something had happened in my lumbar spine. And so what we didn't know and what nobody really discusses is that ECT is an electrical injury. There are no rubber bumpers in your brain to prevent the electricity from traversing the spine and your entire nervous system. There are no rubber bumpers to keep, your electrical stimulation in a specific spot. And you're putting nearly an amp into not only the nervous system, but the entire cerebrovascular system and vascular system. So this is electricity that's not only impacting the brain, but it's also, activating what's the word? the vagal, the trigeminal vagal complex. And it's also, you have your entire trigeminal nerve system where they put the electrode directly above that, but you also have the entire trigeminal vascular system there too.
Okay.
And so electricity follows the path of least resistance. And so, yeah.
I always thought it went between the two electrodes they place on your head. Is that not the case?
Well,
yeah.
I mean,
yeah. Is it like most of it, but like some of it goes different places?
Well, what happens is the nervous system is designed to communicate using 2 to 4 milliamps of electricity. That's how your nervous system communicates. So the ECT devices, according to Abbott, the publication that he published just this past year, Abbott and company said that the ECT devices have a fixed dose of, depending on the device, 800 to 900 milliamps. Mm-hmm. So that's exponentially more than the 2 to 4 that your nervous system functions on. So as self-preservation, the nervous system, because electricity takes the path of least resistance based on the laws of electromagnetism, the electricity diffuses through the entire body. So though it is, the focal point might be, for example, in bilateral ECT, the focal point is the anterior of the frontal lobes and the brainstem. And in unilateral, the focus is the area actually that, Dr. What's his name? John, I forget his name. He was a neurologist who spoke extensively on the neuropathology of ECT. Dr. Friedberg. He said that when you do the right unilateral, it actually damages the area involved in insight. And so, it exploits, he said that it exploits the brain's anosognosia. So those who are injured don't recognize how injured they are. And so, and the body's built-in defense mechanism diffuses the electricity through the entire body. That's why if you put the cuff on the ankle, that's why you can still see the toe twitch. The toe is twitching because it's responding to the electricity in that toe. In the foot, if you've put the cuff on the foot, sure, the toe is twitching because of the electricity of that thing. So. Okay.
And, another thing I wanted to ask, when did you find out that the cause of the psychosis was this sort of fungal infection? When did you get that piece of information?
Oh my goodness. So what happened was I carefully titrated off all of my medications in 2015. They'd stopped working. I'd found some people who did a lot of research on micronutrition, Bonnie and the wonderful woman in New Zealand. I'm sorry, my ECT brain is not coming up with names, but there's a woman, a PhD in Canada and a PhD in New Zealand that have researched extensively, third-party research on micronutrients. And once I found that, I was like, you know what? Maybe I can use this to control my symptoms instead of using the psychiatric medication. So I carefully tapered off all of my medications with the help of wonderful doctors and support. And then I was in the throes of the protracted withdrawals. And I've heard of a doctor who was doing amino acid and NAD supplementation that could help alleviate these protracted withdrawals. And so I contacted him, and in the intake, he started interviewing me, and he took an extremely extensive, medical history. And when he learned of my history with all of the allergies and the chronic bronchitis and the chronic ear infections and the chronic sinus infections of childhood. He said, how many antibiotics did you have when you were a kid? And I was like, well, I was a repeat offender. They were always giving me amoxicillin, 4 to 6 times a year. And he said, through your childhood? And I was like, yeah. And we just had these treatment resistant infections that were just coming back and coming back. And he said, well, your natural stomach has, the natural yeast and everything in it. And sometimes people who are overprescribed antibiotics or have adverse reactions to these antibiotics, they can get thrush or they can get fungal infections or yeast infections in other parts of the body. And he said, I suspect that what's happened with you, and we can't prove it because there's no way to biopsy this or biopsy the right area to make sure. And there's really no test for this. But he said, I suspect that the natural yeast in your stomach has outgrown your stomach and gone right into the next organ, which is the liver. And so I suspect that now that you have a fungal infection in your liver. And by this time, I was teaching my clinical, psych rehab classes, and we were working in the DSM, and, I was teaching all this to my students, and he's telling me that all of my symptoms are caused by a fungal infection. I laughed that poor doctor up one wall and down the other. It was so bad. And he said, well, Sarah, how long does it take for the drugs, the psychiatric drugs to work? And I said, well, it takes about 6 to 8 weeks typically. And he said, yeah, so you have, oh, my thing is falling down. You have a problem. You have a new marriage. You have a new career, and you have psychosis. And so this can destroy what you have built. So you have a choice. Do you want me to send you to the psychiatric hospital so they can begin another regimen of figuring out the medication for you? Or do you want to try this treatment for the fungal infection? And I was like, well, how long will that take? And he said, we will know within a week whether or not it is the right treatment. And I was like, I mean, that's to me, the risk benefit. I was like, a week versus 8 weeks. And I had already, when I quit ECT, they had actually told me that my doctor, that they had not yet invented the medication that would address my psychiatric symptoms. And I was just supposed to wait until they did, so that, just in a holding pattern until the pharmaceutical companies developed a new med for me. And I was like, forget that. I want to get better. I want to get on with my life. Anyway, so I told my doctor, okay, I will give you a week. And if this doesn't work, then I'm going to have to go back into the hospital and get back on meds. And I was I was beside myself because I just had a new marriage and my new career and everything. Anyway, so he prescribed 2 different antifungal prescriptions, and he radically altered my diet, using the protocol that was developed by Dr. Bruce Seaman. It's called the yeast-free protocol. Dr. Seaman is a child psychiatrist with a PhD in clinical nutrition. He used to work for the NIH. When he was getting his PhD, he was a researcher at the NIH. And so he had this entire protocol addressing something that psychiatry actually recognized back in the 80s. And so, yeah, he developed this entire protocol. And so I began strictly adhering to this diet, which is basically just vegetables and meat. I worked so hard on this diet, and I was completely treatment compliant, as I had been the entire time with all of the other treatments. And I was so violently ill on that first and second day of the antifungals that I almost couldn't continue. And that kind doctor had given me his phone number, and he said, Sarah, it's your choice. You can go into the hospital and they can start the antipsychotics on you again, or you can push through. He said, when you get put on these antibiotics and these antifungals, that sometimes it's harder first than it is to go in the long term. And so I was like, okay. And he had told me, your symptoms will wax and wane. These, the symptoms caused by the antifungals will wax and wane based on the timing of them. So you will take your nystatin, and then you will have, within 20 to 40 minutes, you'll have an influx of just really bad nausea and everything else that goes with that. And then if you watch, you have healthy kidneys. So by the end of 4 hours, that will wash through your system and those symptoms will subside. And then you won't have any more symptoms. But then 4 hours later, it's time to take the next dose. And I was like, okay. So then I was like, so then I'm charting. Okay, I took it at this time, and you know what? About a half an hour before the next dose, I was feeling better and I was no longer as acutely symptomatic. And so, okay, I'll take the next dose. So I did it. And by the end of the week, I let him know that, what, we're onto something, because I was no longer psychotic and my mood had come back in to stability. I was no longer the persistent, agitated mess. And my sleep was beginning to return. Previously, I was in such bad withdrawals, protracted withdrawals, and my brain was so on fire that, I could go to sleep and I would sleep like 20 to 30 minutes at a time. Mm-hmm. And then after we started dropping my brain's inflammation, then it was, I knew that I could take this. He had prescribed the nystatin, and the other antifungal was a more powerful antifungal, but I could only take it, twice a day. But the nystatin, he had me taking every 4 hours, round the clock. And so even when I woke up in the middle of the night, I would take it along with vitamin C and a probiotic, and my brain could calm down and go back to sleep within 40 minutes. So it was just fascinating to me.
And so tell me a little bit about your role sort of in the ECT advocacy space. What have you been doing in that space?
Well, during my graduate program, I recognized that part of the problem I was having was that they had to do a lot of testing on me to understand exactly how bad my deficits were, how deep they were. And it wasn't until I was given the right assessments that they could identify what was wrong with me. And so, through my graduate course, I took 2 semesters of assessments, not only neuropsych assessments, but also all of the physical type assessments. And I began to my entire research for my entire program was on helping people with ECT. And so I was constantly gathering information on how to improve our quality of life post-treatment, so that everyone can return to live a productive life as I had, or as I was working on doing at the time. And so as I dug into the ECT research, I began realizing that they were using something called the MMSE to assess for cognitive problems. Now, the MMSE is the Minnesota, can you say it for me? It's the Minnesota multiphasic something exam.
I thought it was the mini mental state exam.
That's
maybe.
what it is. I'm getting two things confused. Thank you.
Yeah.
Hey, just want to interrupt quickly and just say, if you're enjoying the content that we're producing here, that you consider liking, subscribing, and commenting on the videos. These are the type of things that gets this video kind of pushed to broader audiences, and it can really help us.
Yes, it's the mini mental state exam. So the status exam. So the interesting thing about this MMSE is that my doctor couldn't give me the MMSE and qualify me for these academic accommodations. I had to go through and get a comprehensive assessment. And I started looking at the MMSE, and there's research on, published by Rose et al. That says that, the MMSE can actually be passed by people who are lobotomized. And I'm sorry, but if people who are lobotomized can pass the MMSE, clearly we're not accurately measuring the deficits caused by ECT. And so as I was going through my learning in my assessment classes, my teachers were driving home. If you don't do the right assessment, you're not going to be identifying the deficit. Whoops. Mm-hmm. So this is really important for people who live with ECT injuries, because their doctors are denying them comprehensive assessments because they score within the normal range in the MMSE. And unfortunately, the MMSE is a very gross measurement of cognitive status. And if a lobotomized patient can pass it, it's not effective. It's akin to saying, going to your doctor with a fever and a cough and saying, I really think I have COVID. I'm really struggling with my breathing. I'm really having problems with COVID. I need to be tested for COVID, please. And the doctor saying, oh, go stand on that scale. Oh yeah, your weight's good. You don't have COVID. Don't worry about it. We don't need to do further testing. If you don't do the right tests, you're not going to get the right answer. And that's what's happened.
Has there been any advance in developing a standardized tool that is sensitive to detect the type of ECT neurological damage?
Not a comprehensive one. They've taken steps to move in the right direction, but they are not moving far enough. They're not testing the visual changes. They're not testing the auditory changes. They're not testing the motor changes. And what they're testing, they're not even testing the autobiographical changes. Janus did a wonderful study back in the day where he required all of the ECT recipients to take the test before, an autobiographical test before ECT and then retest afterwards. And he had a woman who had acute allergies, who didn't even remember that she had acute allergies. These are things that she knew before treatment. And so, they've just chosen not to measure the right things. So it was interesting because just last year, or the year before, there was a neuropsychologist who was very well respected in his field who underwent ECT, and he had deficits afterwards. But he also had a team of neuropsychologists who respected him. And so when he said, I'm sorry, this test did not capture my deficits, his team said, which test will? And they just kept testing. And so if you look at that report that they published on him, they go through all of the tests they did on him and all the things he scored normal in, and yet scored completely abnormally, several deviations outside of the norm on these other assessments. And so we really need to look at those comprehensive assessments, neuropsych assessments, but also basic occupational therapy assessments like the box and block test and, balance assessments, because really what we're dealing with, I suspect the reason why so many ECT recipients say that they lose the capacity to create new memories is because of the consolidation issue. When you are not understanding, your vision and your auditory systems are permanently altered, you are, what's it called? You're not able to take in the information, and then because it's not taken in well, then it cannot consolidate. And you consolidate memory while you're sleeping. So, if you're having problems sleeping, that's just not going to work.
Do you think there's any movement towards do you think there's been any movement towards greater recognition of the harm of ECT in, I guess, the mainstream medical community?
I'm uncertain. I hope there is, because I worked with some wonderful people who specialize in electrical injury. Right now I'm researching the consequences of electrical injury with Dr. Beatrice Gollum and Dr. Mark Yeske. Dr. Mark Yeske is a Canadian burn surgeon who began working with people with a history of electrical injury back in the 90s at Shriners Hospital. He's working with children who bit live wires and in charge of their care, all the reconstruction that had to do for these electrical injuries. And he would follow these patients. And, it's now been 30 years. And he began recognizing that there were some very real long-term consequences of electrical injury. And for some reason, psychiatry has chosen to focus entirely on mood improvement, and to completely silo mood from the rest of the neurological processes of the brain. And so I think that once we begin looking at other aspects, if you take all of the articles written on electrical injury and compare them to what patients are reporting who have a history of ECT, with the motor problems, with the dystonia, the muscle spasms, the hoarse voice, when we get really tired, we lose the ability to speak altogether. So I have here, I can back up a little bit. I have my keyboard here. I have my mounted speech device on my wheelchair. That's because my nervous system is basically losing the ability to use electrolytes. And so my entire body, has been short-circuited. Mm-hmm. Psychiatry refers to ECT kind of as like a rebooting of the brain. But Dr. Witt, let's be serious. Have you ever rebooted your computer with a power surge?
No. Yeah. Yeah.
We have surge protectors to prevent that, right?
Yep.
And so, it's the same with the body, and the body is even more delicate. So my question to you, because as a psychiatrist, talk to me about your medical education. When you went through, even your prerequisites to even get into medical school, did you take biochemistry class? No?
I mean, I did biology and chemistry in high school.
Of course.
Lots of my colleagues did focuses on that in undergrad. I did not. So I just went, I did a Bachelor of Arts. And so most of my physiology and chemistry was kind of, not really even taught in medical school. I remember going to the basic kind of physiology labs. And that's where we kind of learned hands-on physics related to the human body. But that was about it for me.
Yeah.
Mm-hmm.
So, but when you were in medical school, you learned about, for example, the neurotransmitters and how the drug's affinity to the neurotransmitter receptors, those things that they discussed in medical school?
Not really. I got kind of, I remember a very brief series of lectures on psychiatry. And I remember seeing a neuron at one stage with a receptor, and they said, this is how we think the antidepressants work. There's something about receptor modulation that seems to be really helpful in depression. And that was essentially it for medical school. I learned more in residency, but that was that was the medical school version.
Wow, that's really fascinating. The reason I ask is because I have this book of pharmacology, and in the back of it, it goes through all of the psychotropic medications and their affinity for the neurotransmitter receptor. Mm-hmm. And it says between plus and 5 pluses. So it's this really acts on it, or just kind of acts on it. And so, those are things that you need to know as a resident to begin your rounds so that you understand the prescribing, right? You can't just, okay, psychiatry prescribing is kind of interesting because there's no biomarkers, right?
Yeah, I'd say it's a lot cruder than, what you'd like to imagine. There's antidepressants and, if you've diagnosed someone with 5 out of 9 symptoms for greater than 2 weeks, then they have a major depressive disorder, and then we have a range of treatments that we could use for it. I mean, that's how we are taught to practice.
Yeah.
Yeah.
It's fascinating that you say that, because my doctor was always telling me, well, Sarah, these meds are like, you need to take them for the rest of your life, just like a diabetic. And that really rang home to me because my mom was type 1 diabetic. And for the first, I forget, it was 8 or 12 years of my life, my mom was allergic to all of the available insulins on the market. And so my mom spent a lot of times in comas because her blood sugar would get too high. And then when she was extremely regimented on her diet, then she would go the other direction because her blood sugars would get too low and she'd fall into a coma, and then they'd have to give her sugar in an IV, and then it would go too high. And it was really difficult. And so when my doctor told me I needed these medications like a diabetic needed insulin, it really rang true to me. But then I was the pest because I was like, my mom tests her blood before every meal so that she knows how much insulin to take. And I said, so how are you prescribing these drugs? Because you're not doing blood work on me, right? Like, you're saying I need more serotonin. You're saying I need more dopamine or whatever, or I have too much dopamine, but where's the blood work? And my doctor would get really upset with me, but he kept telling me, this is like a diabetic needs insulin. And I have a mom that had, type 1 diabetes. I understood insulin. So I was extremely diligent in taking my medication, but it kindly got to the point where I realized my doctor was taking the shotgun approach to treating based on symptoms, not treating based on symptom cause. And so that's why I finally made the hard decision to go off the psychiatric medications, because I needed to address the symptom etiology and not just try to force my brain and my body to function. And so, yeah. So the interesting thing, contrary to prescribing practices for drugs, the laws of electricity are very exact. They are so exact, they're referred to as the laws of electromagnetism. It is a natural law governing electricity in the universe. And it's so exact and so precise that it can be written as a mathematical equation. So while psychiatry says they don't know how ECT works, we do know how the ECT device functions. And it functions, they put an electrode on one side of the head and an electrode on the other side of the head. And though the device itself is plugged into an outlet that has direct current, the machine changes it from direct current to alternating current. So one electrode pulses positive charge and one electrode pulses negative charge, and they alternate. So all electrons in the body, based on the laws of electromagnetism, are pulled towards the positive charge and then pulled towards the negative charge. And if you look at the patent for the thymatron machine, these pulses, I just saw that I was reading this patent yesterday. The pulses are like 120 to 100 and I forget exactly the numbers, but it's more than 100 pulses, and there's a range of pulses per second. And then the actual ECT device can discharge this current for 8 seconds, up to 8 seconds. So a psychiatrist, without any subspecialty training in biophysics, without any subspecialty training in the histopathology of electrical injury, without any subspecialty training in the neuropathology of the treatment he's prescribing, a psychiatrist is given the reins to have a machine in front of him or her where they are in charge of configuring a dose. Now, you've seen the ECT machine, so they have it has a fixed current, and then it also has a Hertz dial. It has depending on the device, it has like a percentage of power dial. Anyway, at 100%, it also has a pulse width, so you can change between all of the different pulse widths. And so, I mean, think of all of the variables involved in configuring an ECT dose. You have the power as a psychiatrist. You're privileged to choose on this device which dose your patient is going to get, but you have to choose from more than 500 doses. Now, from an FDA perspective, as a device, I mean, as a drug person who sat on the drug committee, when a pharmaceutical company came to you and said, "We've got a new drug, here, use it," were they required to have dosing consensus standards?
Yes.
Yes. Were they required to have dosing consensus standards based on safety studies?
Yes.
So they had to establish the safe range of dose, right? So that is not done for ECT. ECT, the devices were grandfathered in when the FDA decided that they were going to start regulating devices. And since it was already in use, they said, well, we're going to keep using it because you guys have already been using it since the 40s. And so it's a now officially grandfathered device. Well, what happened was psychiatry started getting a bad rep because there was a book that came out and then a movie that was very famous. Mind you, I've never seen this movie, and I didn't even learn about this movie till after I had ECT.
Yeah, the one who flew over the cuckoo's nest, right?
Exactly.
Yeah.
And so psychiatry had this massive PR problem on their hands because here we have Jack Nicholson getting ECT on a cinematic screen in front of entire audiences. And back in the 60s, this was just, I think the movie came out before I was born even. And so audiences were appalled. And so psychiatry said, we need to launch a PR campaign because, we're going to not do it like this movie. And at the time, there were still hospitals that were giving ECT without anesthesia. So they decided unilaterally in America, we're always going to use anesthesia and we're always going to use a paralytic. And they call it a muscle relaxant, but it's a paralytic. It paralyzes the respiratory muscles and everything. And so then they said, you can come in and watch us give ECT because look, the patient is just nice and quiet and peaceful. They're not pain, there's no pain involved. There's no convulsion. You can't see a convulsion, but there is a convulsion on the EEG machine. Anyway, so the problem was once they introduced this anesthesia, general anesthesia, psychiatry had a problem because now they could no longer use the machines that they were previously using. Because as a doctor, if you have a patient who comes into the ER in a seizure, what class of medication do you give them to stop the seizure?
Yeah, usually benzos.
Exactly. Benzos or some kind of anticonvulsant that also, or a tranquilizer. And that's basically the same class of medication as anesthesia. So here we have doctors raising the seizure threshold so the body will not go into a seizure. And so the American Psychiatric Association and the ECT task force actually approached both manufacturers of the devices and said, or at the time there was just one manufacturer and said, we need a stronger device. They petitioned the manufacturer to make a stronger device. And so the MECTA, that was the company at the time, said, we'll make a stronger device for you. So they made a stronger device. And then they got it grandfathered in because it was sufficiently the same as the previously used device.
So do you think ECT was safer back when they did it without anesthesia because they used a lower powered device?
Well, I don't know that it was safer because the body functions on 2 to 4 milliamps.
Okay.
So when you get above 4 milliamps, when you get to, I don't know if you look at like the work, vocational safety guidelines for like OSHA, it will tell you the OSHA standards for electricity to the body. And when you get above those standards, it's going to cause damage. It's going to cause injury. And so, I don't think it was safe back then. And I know it's not safe now because back then, if you look at the old research, they're using 60 to 150 volts. They don't always say exactly how much current they use. Frequently they don't say how much current they use. And so, but these modern devices are nearly an amp without any, and I quote, without any clinical or scientific rationale. They have a fixed dose at nearly an amp. And then, they can go all the way up to 450 volts, depending on the device. Or they can go, in America, it's 504 millicoulombs is the cutoff, but across the pond, they can go, or for the Thymatron, and I think across the pond, the European devices sold by the American manufacturers have an even larger amount of millicoulombs produced. Okay. And so, in America, you can have up to 500 more than 500 doses. But if you add all those extra millicoulombs, you can have who knows how many possible doses on a European device made in America.
Wow. Okay. Well, this is like a lot of stuff I didn't know. I do need to wrap up in about 5 minutes. So I was wondering what else is important to share while we have this time together.
Well, I think what's most important to share is in 2018, December 26th, 2018, the FDA decided to reclassify the ECT device. And when they did, they made it a class 2 device with the class 2 only for major depressive disorder and catatonia. For every other diagnosis, it is still a class 3 device.
What's the distinction? Why is that important?
A class 3 device means that it is an experimental device. A class 2 device means that it has been found safe and effective. And I saw your video on safe and effective and how the FDA defines that. So that means that, the benefits outweigh the risks. So what happens is when they made that reclassification decision on December 26, 2018, they said, we give you 90 days to submit your pre-market approval studies and your product development protocols. So that's your safety studies and your dosing consensus standards, and to use the language they use for drugs. We give you until March 26th to submit it for all class 3 uses. So schizoaffective disorder, schizophrenia, bipolar, OCD, mania, for all of that. We'll give you until March 26th of 2019 to submit that PDP. And we'll give you until, I think it's June 26th of 2019 to submit it for the major depression and catatonia. Mm-hmm. And they said, if it is not submitted, if your PMA and PDP is not submitted by these dates, this device is deemed adulterated. Now, when a device is deemed adulterated, that means it is no longer allowed to be used unless the institution using it submits an IDE, which I forget what that stands for. What does an IDE stand for?
investigational device exemption, maybe?
Yes,
is that what it
that's
is?
exactly what it is. Thank you.
Yeah.
So they must submit an IDE to the FDA, and they must get that approved before they can proceed. So this is interesting because the court case here in Florida that they just had, the court case revealed, the subpoenaed records revealed that the device in question in the court case, the Thymatron device, had never submitted any product development protocol or any PMA to the FDA because it was a grandfathered device. Even though the FDA requested it at each of the device hearings, they just stalled and never submitted it. And in deposition, both the co-owners of this device, Richard Abrams and Conrad Schwartz, they said that it is not their business to conduct safety testing.
Yeah.
So
it's, they're an interesting group because I bet you they don't make a lot of money selling Thymatrons because it's you sell a machine, it just sits in a hospital, it's old technology, and so
exactly.
I imagine they would just say we don't care, but then all of the doctors would throw a fit and say we need these devices.
Exactly.
Yeah.
Well, and the doctors and the institutions, the institutions are making bank, and I say that because they can. You can Medicare,
charge a lot for ECT, right?
You can charge a lot for ECT privately, and through Medicare and Medicaid, you can bill in perpetuity. There are no limits. So this becomes a problem because it has become their golden goose for funding their units because it's the most lucrative thing that they can do in an institution in terms of billing for psychiatric treatment. And
that is true. That it makes a lot more money to do a procedure, than med management or psychotherapy. It probably is the most profitable thing that a psychiatric institution could do from an insurance standpoint.
Oh, of course. If you look at the psychiatry's form, they're discussing, the money is made by the volume of patients given ECT. And when a outpatient clinic or a hospital clinic that does both inpatient and an outpatient, when they have a streamlined staff, they can do a patient every 15 to 20 minutes. So that's one psychiatrist doing a patient every 15 to 20 minutes. All he has to do is push a button. Now, this is problematic because there are 5 different dosing methods. Not even the Dr. Abrams and Dr. Schwartz, not even they agree on dosing methodology. They've published multiple papers. There's at least 5, actually 6 potential.
Well, isn't the dose? I'm trying to remember because I've been in ECT rooms before. I've seen it done. Isn't the idea that you're meant to elicit a seizure, and that's like, if you get to that level, that's kind of when you stop. Is that typically, is that what is done? Like
that's one of the seizure. That's one of the methods. One of them is called the benchmark method. Then there's the age-based dosing method. There's actually, they've just suggested starting using a 6th dosing method, which is the Scandinavian dosing method. And so, even amongst themselves, they have said, they need, just at the last Nordic conference, they were showing articles from even device representatives like Dr. Declan McLaughlin, who's a MECTA rep. He said, the dose that maximizes benefit and minimizes cognitive deficit is not known. And they're not telling patients this. And they just published a study just this past week, that said that it was between 42 and I think 58% of the ECT recipients did not respond to treatment. And they tracked them with MRI before immediately after and 2 years after ECT. And 2 years after ECT, immediately, like they got established baseline. Immediately after ECT, they had an enlarged areas in the brain. And then in the past, they always attributed that to, sprouting and magical growth that improves life. And this is great. Well, that's not based on neuropathology studies. That's all hypothetical and wrong based on neuropathology studies. But then you go the 2 year after and look at the MRI, and those exact same areas that were enlarged are now shrunk. And these people have cerebral atrophy.
Yeah.
So they're even more atrophied than their baseline. And they were distinct from people who had all of the same symptoms who did not receive ECT. So, we're inducing cerebral atrophy. We're inducing a spike in blood pressure that's 300%. We're inducing a spike in glucose use and in oxygen use that's 200%. The body is completely the metabolic of the seizure outstrips the metabolic function of the brain and flatlines brain activity for up to more than 6 minutes. During that time, the person is not taking in air. You have to use the bag, the AMBO bag, and there's no capnography used. It's not a gold standard. Capnography is not a gold standard in ECT use. And so you have patients who can get hypoxic and anoxic brain injury during that when their brain shuts off and they're not breathing. And even if their oxygen saturation remains within good limits, Posner demonstrated that because of the metabolic outstripping of the glucose and the nutrition in the brain, plus the subsequent acute bradycardia, and 68% of the people in this one study had asystole. We're talking major consequences. And that's a repetitive traumatic brain injury. So you have a loss of consciousness that lasts longer than the fast-acting anesthesia. The fast-acting anesthesia like Bravita lasts, 5-10 minutes?
Okay.
Half-life. And then you have a loss of consciousness that can go from 10 to 40 plus minutes. So that entire additional time, the person is in a coma. That is a loss of consciousness. The Department of Defense classifies a traumatic brain injury, a mild traumatic brain injury, as a loss of consciousness that's between 0 and 30 minutes. And moderate traumatic brain injury is from 30 minutes to 24 hours. And so that means with every single treatment, these recipients are getting a traumatic brain injury, either mild or moderate, depending on how long they're unconscious.
Okay.
We know what repetitive brain injuries does to humans.
You look at the football players. Yeah.
Exactly. Yeah. So
I
guess my closing, I created a petition, and the petition is to audit ECT use because we need to understand the numbers. We need a needs assessment to recognize how many people are affected by this, because they've been using the same 100,000 since the 70s. And I'm sorry, but that was an arbitrary number to begin with. And then, so my petition can be found at change.org /patient safety ECT. Now has more than 15,000 signatures. And in addition to auditing it, we need to ensure that every single recipient is automatically referred for rehabilitation, comprehensive assessments for rehabilitation, and given rehabilitation as indicated so that they can regain quality of life, so that their families can understand just how bad this repetitive brain injury is and be more sympathetic, because at this time their families are hearing from their doctors that it's all in their head. Yes, it's not in their mind, it is in their head. So we need to get these people help. My people. I say these people, but I mean my people.
Well, thank you so much for coming on and sharing your story and telling me about the petition. You taught me a lot about ECT brain injuries, and I'm really grateful for that.
You're welcome. And Joseph, sorry, Dr. Witt, so the other aspect of my advocacy you'd asked about is I am really working to help people get help afterwards. And so I have actually started a foundation that's called the Ionic Injury Foundation. And we're working to understand the immediate and long-term consequences of electrical injury. And the Ionic Injury Foundation, I'm currently in the process of fundraising so that we can have an endowment to study these injuries long-term and better develop the rehabilitation, because the FDA recognizes that the long-term safety and effectiveness of ECT has not been demonstrated, and they recommend long-term follow-up, but there is no identified rehabilitation or long-term follow-up recognized. And so I'm working in the process of developing that.
It's fantastic. I'll be following you closely. So thank you once more. I really appreciate it.
I appreciate your time and the opportunity to share my experience and to help those with these injuries and to prevent others from being subjected to unwitting human experimentation.